wabarakatuh. My dear students, I hope you are all well and your families are well with the grace of God. And I pray that we all meet once again in the lecture hall. So, Bismillahirrahmanirrahim. Today our topic of discussion is maternal collapse during pregnancy, and later we will also discuss sepsis in obstetrics. Of today's talk is to discuss the identification of women at increased risk of maternal collapse, to identify different causes of maternal collapse, to delineate the initial and continuing management of maternal collapse, to review maternal and fetal outcomes. So these are the objectives. Bismillahirrahmanirrahim. So we will start today with maternal collapse during pregnancy. The objectives of today's lecture is to discuss the identification of women at risk, increased risk of maternal collapse, to identify different causes of it, to delineate initial and continuing management of maternal collapse, and to review maternal and fetal outcomes. Now, what is maternal collapse? Maternal collapse is defined as an acute event involving the cardiorespiratory system and or brain, resulting in a reduced or absent conscious level and potentially death at any stage in pregnancy and up to 6 weeks after delivery. So this is how we define maternal collapse. Can women at risk of impending collapse be identified early? An obstetric early warning score chart should be used routinely for all women to allow early recognition of the women who is becoming critically ill. So it depends on previous risk factors during pregnancy. The first modified early obstetric warning scoring, that is MUOS systems, were introduced on the basis that a deterioration in simple physiological vital signs will precede significant clinical deterioration, and that early intervention will reduce the morbidity. So what can cause maternal collapse? There are reversible causes, 4H. It includes hypovolemia, hypoxia, hypokalemia or hyperkalemia, hypothermia. So these are the 4H: hypovolemia, hypoxia, hypokalemia, hyperkalemia, or hypothermia. Then 4T, which includes thromboembolism, toxicity related to drugs or anesthesia, tension pneumothorax, or cardiac tamponade. So these are the reversible causes which can lead to maternal collapse. Hemorrhage. This is the most common cause of maternal collapse and was responsible for 1.7 maternal deaths in the last 3 years. Hemorrhage may be revealed or concealed. Revealed hemorrhage may be due to postpartum hemorrhage or antepartum hemorrhage from placental previa, placental abruption, spine rupture, or it may be due to ectopic pregnancy. Now, causes of concealed hemorrhage may be placental abruption. There is hemorrhage which is retroplacental clot and it is not revealed. It is not bleeding per vagina. Or splenic artery rupture, which causes intraperitoneal bleeding, and hepatic rupture, which also leads to intraperitoneal bleeding. Thromboembolism, the most common cause of direct maternal death. About 50% of maternal venous thromboembolic events occur during pregnancy. Appropriate use of thromboprophylaxis has improved maternal improvement in clinical risk assessment and prophylaxis. Amniotic fluid embolism. Sometimes when we rupture the membrane, the amniotic fluid expels through open maternal sinuses into the maternal circulation, and this embolism may lead to maternal collapse. The estimated frequency of amniotic fluid embolism lies somewhere between 1.25 per 100,000 and 12.5 per 100,000 maternity, with the most recent UK data giving an incidence of 2 per 100,000 maternity. There is biphasic response in amniotic fluid embolism. In the first phase, within 30 minutes, there is pulmonary vasospasm. As soon as the amniotic embolus enters the pulmonary vessels, it causes vasospasm over there, which leads to pulmonary hypertension, right heart dysfunction, and in the second phase, left ventricular failure with pulmonary edema, adult respiratory distress syndrome, and ultimately DIC. So this is how amniotic fluid embolism causes maternal collapse. Now the cardiac diseases. Cardiac disease was the most common cause of maternal death. Maternal collapse due to cardiac disease include myocardial infarction, if the patient gets MI during pregnancy, aortic dissection, cardiomyopathies, dissection of the coronary arteries, acute left ventricular failure, or infective endocarditis. Sepsis is the leading cause of maternal morbidity and death in the developing countries. It is bacteremia, which can be present in the absence of pyrexia or a raised WBC count. It can progress rapidly to severe sepsis and septic shock, leading to collapse. The most common organisms which are responsible for sepsis in obstetrics are groups A, B, T, streptococci, pneumococcus, and E. coli. Drug toxicity. The drugs include magnesium sulfate. It causes renal impairment. Or anesthetic drugs, which cause a feeling of lightheadedness, followed by sedation, paresthesia, and switching. Convulsions can occur in severe toxicity. If IV injection is given, convulsions and cardiovascular collapse may occur very rapidly. Seizures are also responsible for maternal collapse. It includes eclampsia or epilepsy. Intracranial hemorrhage. Intracranial hemorrhage is a significant complication of uncontrolled, particularly systolic hypertension, but can also result from ruptured aneurysm, malformation. The initial presentation may be maternal collapse, but often severe hepatic disease. Anaphylaxis is likely when all of the following three criteria are met: sudden onset and progression symptoms, life-threatening airway or breathing and or circulation problems, skin and or mucosal changes, which include flushing, urticaria, and angioedema, exposure to a known allergen for the women, supports diagnosis, but many cases occur with no clinical. The other causes of collapse include hypoglycemia, severe hypoglycemia, other metabolic or electrolyte disturbances, other causes of hypoxia such as airway obstruction, secondary to aspiration, or foreign body. Air embolism, tension pneumothorax, cardiac tamponade due to trauma, and hypothyroidism. Now there are certain problems during pregnancy which makes the resuscitation of the collapsed mother difficult. There is the most common is aortocaval compression. Aortocaval compression significantly reduces the efficacy of chest compression during resuscitation. When cardiopulmonary arrest occurs, chest compression contributes to the cardiac output. In non-pregnant women, the chest compressions achieve around 30% of the normal cardiac output. But if a patient is pregnant, these compressions further reduces cardiac output to around 10% and it get achieved in non-pregnant women. So CPR is less likely to be effective in a woman who is 20 weeks pregnant or more. So this in the picture you can see that this is the gravid uterus and this is the inferior vena cava. The pressure of this gravid uterus compresses the inferior vena cava, which leads to decreased venous pooling in the lower limbs and decreased venous return to the heart, which ultimately leads to supine hypotension. So this is aortocaval compression. Now there are certain respiratory changes during pregnancy. Changes in the lung function, diaphragmatic splinting, and increased oxygen consumption make the pregnant woman become hypoxic more readily and make ventilation more difficult. And the pregnancy increases the respiratory drive, leading to an increase in tidal volume and minute ventilation. Splinting of the diaphragm by the enlarged uterus reduces the functional respiratory capacity and also makes ventilation more difficult. These factors, along with a markedly increased oxygen consumption of the pituitary unit, mean that the pregnant woman becomes hypoxic much more rapidly due to periods of hypoventilation. So these respiratory changes make the pregnant lady more vulnerable to hypoxia due to hypoventilation. In pregnancy, intubation is also difficult due to the, like in preeclampsia or eclampsia due to laryngeal edema. Aspiration. Pregnant women are at an increased risk of aspiration, including aspiration pneumonitis, that is Mendelssohn syndrome. Early intubation with effective record pressure and the use of H2 antagonist and antacids prophylactically in all women considered to be at high risk of obstetric intervention during labor is advised. So whenever we are planning a surgery for a pregnant lady, we have the patient with the NPO. If she is not, and we must give H2 antagonist and antacid before the surgery so as to avoid the aspiration pneumonitis or Mendelssohn syndrome. Circulation. Healthy women tolerate blood loss remarkably well and can lose up to 35% of the circulation before becoming symptomatic. Blood loss is tolerated less well and importantly less efficient if there is a pre-existing maternal anemia. If the patient is already anemic, she has low reserves. So any small amount of blood loss, it will lead to significant hypoxia and patient may go into shock. Now how we can manage a maternal collapse or what are the steps of resuscitation in a maternal collapse? Initial resuscitation, investigations and monitoring, communication among the staff, and the patient and her family, and treating the cause. Now, what is the optimal initial management of maternal? Maternal resuscitation should follow the resuscitation council guidelines using the standard ABCD approach with some modifications. Resuscitation is conducted by basic life support, that is BLS, adult advanced life support, ALS, and automated AED if required, if there is a patient has cardiogenic. The first of all, if the patient is 20 weeks or more pregnant, the pressure of the gravid uterus must be relieved from the inferior vena cava and aorta. This is done by a left lateral tilt of 15 degrees on a firm surface. It will relieve aortocaval compression in the majority of pregnant women and will still allow effective chest compressions to be performed. So, lateral tilt of about 15 to 20 degrees. So in this picture, you can see the mother is being resuscitated. Here, the chest compressions, they are given with a ventilation. The patient is intubated, and at the same time, there is aortocaval compression is relieved by lateral tilt, which is about 15 to 20 degrees, and with left uterine displacement. This is left uterine displacement. We are displacing the uterus towards the left side so as to relieve the aortocaval compression. Now A is airway. The airway should be protected as soon as possible by intubation with a cuffed intubation tube for intubation. Second, women is more likely to regurgitate and aspirate in the absence of a secured airway than the non-pregnant patient, and that the early involvement of an appropriate is women's best practice. B is for breathing with ventilation. Look for the chest movement. You have seen a collapsed patient. You look for the chest movement, listen for the breath sound, and feel for the movement of air for a maximum of 10 seconds. See whether the patient is breathing or not. If breathing is present, give diaphragmatic. Breathing is absent, then start ventilation. Now C, the circulation with hemorrhage control. Absent breathing in the presence of a clear airway. There is breathing, but airway is there is no breathing, but airway is clear. Is now used as a marker of absence of circulation. No circulation, we should start CPR, that is cardiopulmonary resuscitation. How we do CPR? We give 30 chest compression and 2 ventilation, 2 breaths and 30 chest compression. After every 30 chest compression, 2 ventilations they are given. Manage hypovolemia or hemorrhage concurrently. At the same time, you will not forget to manage hypovolemia or hemorrhage. So this is C, circulation. Now disability. D for disability. Neurological status using the AVPU score. That is alert, respond to voice, respond to pain, and unresponsiveness. So this is AVPU score. So the neurological status is assessed by AVPU scoring. Following initial resuscitation, perform a class score. If it is less than 8, indicates the patient requires intubation. So disability is assessed with AVPU and class of coma score, whether the patient requires intubation or not. E for exposure. Depending on the environment, perform full body examination of the patient, remembering risks of hypothermia and patient dignity. Monitor blood pressure, pulse oximetry, ECG, and tidal carbon dioxide, and respiratory rate. Consider urinary catheter and nasogastric tube. Now resuscitation. After doing this A, B, C, D, E, we are at the same time doing resuscitation. Deal with any problem you find. Consider differential diagnosis. What is the reason? What is the cause of maternal collapse? Assess fetal well-being and viability with the help of CTG and ultrasound, whether the baby is alive or not alive. The baby is not in distress with the help of CTG, that is cardiotomogram. Notes review. At the same time, you are entering all the things in your notes. You do trends of vital signs and notes. Then definitive care is order the lab, send all the case investigations and investigations, plan treatment depending on the underlying cause. So this was all about the resuscitation of a collapsed mother. Now, if the patient is 20 weeks or more than 20 weeks pregnant, and you are resuscitating the mother, and the baby is alive, you have done aortocaval compression and left uterine displacement. You have relieved aortocaval compression and you have done left uterine displacement. And within 4 minutes, the patient is not reviving. You have to think of delivering the patient by emergency or perimortem cesarean section. This is postmortem cesarean section. It should be done within first 5 minutes of the resuscitation. When, where, and how should perimortem cesarean section be performed? If there is no response to correctly perform CPR, it can form of maternal collapse, or if resuscitation is continued beyond this in women beyond 20 weeks of gestation, this should be undertaken to assist maternal resuscitation. This should be achieved within 5 minutes of the collapse. Perimortem cesarean section should not be delayed by movement. It should be performed where resuscitation is taking place. You are not supposed to shift the patient to OR for this. The operator should choose the incision that will facilitate the most rapid access. A perimortem cesarean section tray should be available on the resuscitation trolley in all areas where maternal collapse may occur, including the accident and emergency department. Now, in this picture, you can see the technique of perimortem cesarean section. You have to give a longitudinal midline incision, vertical incision. It will start from the xiphoid to pubis. It is continuous straight down to the abdominal wall and peritoneum. You have to open the skin, fascia, rectus sheath, and muscles, and enter the uterine cavity, and cut through the uterus and placenta if anterior, longitudinal, or transverse. It doesn't matter you open the uterus transversely or longitudinally. Bluntly open uterus and remove fetus, cut, clamp, cord, and hand it over to the fetusation. So this is the technique of perimortem cesarean section. Again, in this picture, you can see this is the incision starting from the uterus, sternum, tail, upper part of the pubis symphysis, midline longitudinal incision, cut through the uterus and open the uterus longitudinally or transversely. The prognosis for intact survival of infant best if delivered within 5 minutes of the maternal arrest. The goal of this all exercise is to remove fetus and continue resuscitation of mother and the fetus. During the procedure, maternal CPR has to be continued. You are not abandoning the CPR. You will continue CPR during this procedure. Vertical midline abdominal incision from 4 to 5 centimeters. Deferred process to sensitive and inside. What does the continuing management consist of? Senior staff with experience should be involved at an early stage. You must involve everybody. Senior personnel, along with you. Transfer should be supervised by an adequately skilled team with appropriate equipment if it is needed. Okay, the hemorrhage as a cause of maternal collapse. Hemorrhage may be secondary to antepartum hemorrhage. The fetus and placenta should be delivered promptly to allow control of the hemorrhage. In case of massive placental ruption, such an evolution is indicated even if the fetus is dead to allow rapid control of the hemorrhage. To save the mother, we will do cesarean section if there is massive placental abruption and the mother's life is compromised. Now the key learning points regarding maternal collapse. Whenever you find a collapsed mother, obtain a left lateral rate of 15 to 20 degrees at the earliest opportunity to prevent cesarean compression. Resuscitation of the pregnant mother is more difficult due to reduced lung capacity, reduced venous return is defined, greater oxygen demand from the fetus, and increased weight. The use of MEO score, that is modified early obstetric warning sign score, are key in the early recognition of apparent deterioration of a patient. If you use this score, you can early recognize the deterioration in the condition of the patient. So these are the 3 key points regarding maternal collapse. Sepsis or septic shock. Sepsis is an important cause of maternal death in developing countries, as most of our deliveries are in accepted by local birth attendants and guides and midwives at home without any aseptic measure. Sepsis may be defined as infection plus systemic manifestations of the infection. Septic shock is defined as persistence of hyperperfusion despite adequate fluid replacement therapy. If the patient has sepsis and she is being given fluid, but the hyperperfusion persists despite adequate fluid replacement therapy. So such patients they are called in septic shock. What are the risk factors? Each patient they may have sepsis. Patients with ruptured membrane, those patients who have early ruptured membrane or prolonged ruptured membrane, they may develop chorioamnitis and it may be endomyocytes and sepsis later. Immunocompromised patients, those patients who are already on immunosuppressive drugs or are taking steroids or they have other problems. So such immunocompromised patients then is obesity, morbid obesity, it is also a risk factor because if a patient she is morbidly obese and her injection is being done, so what happens due to this morbid obesity? Her whole of the abdomen it will come over to the injection wound and it will obstruct the oxygenation of the wound. And ultimately, there will be colonization of the bacteria for that area and there will be wound infection. Wound infection may further lead to cellulitis over that area. Especially morbid obesity is one of the risk factors for diabetes. In diabetes, if uncontrolled diabetes, the patient she may have risk of sepsis, that is wound infection or episodic tissues they may get infected or she may develop endometriosis or she may develop anemia. What happens in anemia? There is less oxygen getting capacity of the hemoglobin. There is reduced hemoglobin, so there is tissue anoxia, and this tissue anoxia it will lead to development of UTI, recurrent UTI, a chronic UTI, urinary tract infection. It may lead to sepsis. It may develop, the patient may develop pyelonephritis, or she may develop severe urinary tract infection, and it may endanger the life of the patient. Vaginal discharge. If she has profuse, virulent, copious vaginal discharge, it may lead to systemic infection. She may develop peritonitis, endometritis, salpingitis, or pelvic peritonitis. So, ascending infection will lead to sepsis. Previous pelvic infection. If she had previous history of like inflammatory disease, there are more chances she may develop this time severe sepsis. Now, group B streptococcal infection. If the patient has group B streptococcal infection, she may develop sepsis. Amniocentesis or any other invasive procedures, they may also lead to development of the sepsis. Cervical circulation is also an intervention during pregnancy. If aseptic are not practiced, it may lead to ascending infection and group A streptococcal infection. So these are the risk factors for sepsis. Septic membranes, immunization, diabetes, anemia, UTI, vaginal discharge, leading to ascending infection, previously IDs, and group B streptococcal infection. Amniocentesis and other invasive procedures, cervical circulation, group A streptococcal infection. Now, these are the stages of sepsis. Initially, there is systemic inflammatory response syndrome, SIR, which have following four criteria. Two or more of the following is present, then the patient has SIR. Temperature more than 38 degrees or less than 36 degrees. Heart rate more than 90. Respiratory rate more than 20. WBC count more than 12 or less than 4, which is 1.9 per liter, or 10% of band form. So this is SIRS, that is systemic inflammatory response syndrome. Next stage is sepsis. SIRS plus a culture documented stage. If the culture is positive also, then this is sepsis. Severe sepsis is then there is organ dysfunction along with sepsis, hypotension or hypoperfusion, and septic shock. If hypotension or hypoperfusion persists despite adequate fluid resuscitation, then this is septic shock. Patient is in shock. She is given fluid, everything, but she is in the state of hypotension and hyperperfusion. Now, what are the preventive strategies to prevent that? All maternal observations should be documented on a MUSE modified early obstetric warning system chart to allow early detection of sepsis and subsequent treatment. So, what we have to do, we have to make a MUSE chart. So, if it's a vital sign, we can early detect it. What are the warning signs? How we will know that the patient is going towards sepsis? It is hypothermia or pyrexia. She may have fever or she may have hypothermia. Tachypnea, increased respiratory rate more than 20. Tachycardia, increased pulse more than 90. Hypotension, if the pressure is falling. Rise in MUSE score, the vital signs are deteriorating from the baseline. Oliguria. What is oliguria? If the urinary output is less than 30 ml per hour, then it is called oliguria. So oliguria is another sign of septicemia. Rigors. If patient is having rigors, chills, or she is developing rash, or she is having reduced level of consciousness, she is becoming drowsy. So these are all the signs, warning signs. Sepsis. Now, how to manage a patient who is having sepsis? Septic shock should be managed in accordance with the surviving sepsis contained guidelines. So we have guidelines. The following care bundle should be applied immediately or within 6 hours and has been shown to significantly improve the survival rate. First of all, obtain blood cultures or culture swab prior to antibiotic administration. We have to send the cultures. It may include blood cultures, high vaginal swab, or nasopharyngeal swab, or a sputum for culture sensitivity before administration of antibiotics. And administer broad spectrum antibiotics within the first hour of recognition of severe sepsis and septic shock according to local protocol. Then measure the serum red plate. In the event of hypotension or lactate is 4 millimoles per liter, give an initial minimum of 20 ml sulfaceous crystalloid or fluid. So we have to give fluids to treat this hypotension. Once adequate volume replacement has been achieved, a vasopressor, epinephrine or norepinephrine, and or an inotrope of glutamine may be used to maintain mean arterial pressure over 65 mm of mercury. Further management consists of, in the event of hypotension, despite fluid resuscitation, you have given fluid, adequate fluid to the patient, but the patient is not improving. She has still hypotension. Then the patient is in septic shock and or lactate is more than 4 millimoles per liter. Achieve a central venous pressure at least more than 8 mmHg with aggressive displacement. So CVP line should be passed and it should be the central venous pressure should be more than 8 millimeters with aggressive fluid replacement. Steroids can be considered with caution. Maintain oxygen saturation. More than 70% with facial oxygen. So oxygen saturation it should be more than 70%. Consider transfusion if hemoglobin is below 7 grams per deciliter in case of hemorrhage or she's anemic. Continuing management involves continuous supportive therapy, removing the septic focus, administration of blood products is required, and thromboprophylaxis. So continuing management involves continuous supportive therapy. If the patient has septic focus before she has just aborted, but there are retained products of conception like the uterus, so we have to remove these products. Or if she has delivered a baby and after delivery she has some retained placenta or membranes inside the uterine cavity, uterus must be evacuated. So we have to remove the septic focus. Otherwise she will not. And if she is anemic, we have to give blood products. We have to give back cells. And if she has thromboembolism, we have to give fresh fluid and some. Involve a microbiologist or infection disease physician early, particularly if women does not respond to first choice antibiotics. Severe sepsis may be defined as temperature more than 38 degrees or less than 36 degrees. So high pyrexia and hypothermia. They are both signs of severe sepsis. Heart rate more than 100 beats per minute. Respiratory rate more than 20 per minute. WBC count more than 17 or less than 4 with more than 10% immature band. Severe sepsis has a higher maternal mortality and requires aggressive prompt treatment and timely involvement of the multidisciplinary team. So what is severe sepsis? If temperature is more than 38 or less than 36, heart rate is more than 100, respiratory rate is more than 20, she is catapnic, or WBC count is more than 17, 4 to 11 is the normal range. So if it is more than 17 or it is with more than 10% immature band, then the patient is going towards severe sepsis. It has high maternal mortality and it requires aggressive prompt treatment and timely involvement of the multidisciplinary team. So we have to involve the microbiologist, infection physician, and hematologist along with the obstetrician. Now, antibiotics. antibiotic use. Selection of antibiotics should be guided by the risk factors and potential sources of sepsis. A combination of either piperacillin or tazobactam or a carbapenem plus clindamycin provides a very broad spectrum coverage for the treatment of sepsis. Comoxiclav, that is augmentin, you are familiar with the name of augmentin. It provides gram-positive and anaerobic cover. It does not cover methicillin-resistant staph aureus, that is MRSA. It is called MRSA. Methicillin-resistant staph aureus, it doesn't cover that. And pseudomonas also. Metronidazole, that is Seizures, provides an anaerobic cover. So it covers the anaerobic organs. Clindamycin, which is available with the name of dalacin C, it covers streptococci, it also switches off exotoxin production. Gentamicin covers gram-negative organisms, coliforms, and pseudomonas. Who should be involved in the collaborative care? In a woman with sepsis suspected, regular frequent observation should be made. The use of a MEOS chart. MEOS stands for Modified Early Obstetric Warning Sign. Chart is recommended. There should be an urgent referral to the critical care team in severe and rapidly deteriorating cases and the involvement of a consultant physician. The expert advice of a consultant microbiologist or infectious disease physician, as I have already told, should be sought urgently when serious sepsis is suspected. The decision to transfer to ICU should be decided by the critical care team in conjunction with the obstetric consultant. Now, the obstetric management. If the patient has sepsis and she is pregnant, in a critically ill pregnant woman, delivery may be considered if it would be beneficial to the mother, the baby, or to both. A decision on the timing and mode of delivery it should be made by a senior obstetrician following discussion with the woman. If preterm delivery is anticipated, cautious consideration should be given to the use of antenatal steroids for fetal lung maturity in the women with sepsis. During the intrapartum period, continuous electronic fetal monitoring is recommended. That is continuous ECG. Changes in the cardiotopography, such as changes in the baseline variability, deceleration, or absence of accelerations, reduced variability, then these are the signs of fetal distress. So must do prompt reassessment of the maternal mean arterial pressure, hypoxia, and acidemia. Epidural or spinal anesthesia, it should be avoided. They are not given if the patient has septicemia. A general anesthesia will usually be required for cesarean. Documentation. Accurate documentation in all cases of maternal collapse, whether or not resuscitation is successful, is essential. Documentation is very important. When you will go into practical life, you will see how much documentation is important. If you have done proper documentation, it will save your skin. If you have informed the seniors at the proper time, it will save your skin. So you have always proper documentation to be. Poor documentation remains a problem in all aspects of medicine and can have potential medical legal consequences. If your documentation is not proper, then suppose the patient expires and the case goes to litigation. In that case, you will be caught. Even if you have done your best and your documentation is poor, you will not be spared because your documentation is your evidence. Okay. Training. So, all generic life support training should make mention of the adaptation of CPR in pregnant women. All maternity staff should have annual formal training in generic life support and the management of maternal collapse. Life support training reduces morbidity and mortality. Now, key points in the management of that. First of all, blood culture before antibiotic administration. Cultures sent on clinical suspicion include HVS, hybrid swab, mixed urine, and sputum culture. Key organisms involved in process sepsis are Lansfield A beta hemolytic streptococci and early diagnosis, rapid administration of antibiotics, review with senior doctors, then midwives reduces mortality and improves the outcome. Measure lactate and hemoglobin. Plan treatment. Plan repeat measurements to have assess the response to initial treatment. Measure accurately hourly urine output. What should be the hourly urine output? It should be 30 ml per hour at least. If it is less than 30 ml per hour, then it is polyurethanes, which is a sign of sepsis. Administer high flow oxygen. So these are the key points or take-home message. Blood cultures before antibiotics. Other cultures which are sent on suspicion are HBS, mixed urine, sputum culture. Key organisms which are involved are A beta hemolytic streptococci and E. coli. So if early diagnosis using neosporin or administration of antibiotics and review by senior doctors and midwives, it reduces mortality and improves the outcome. Lactate, they are measured if they are more than 4, then we have to manage efficiently. And hemoglobin, if it is low, we have to do blood products. We plan the repeat measurements to have assessed response to initial treatment. Urinary output should be measured hourly, and high flow oxygen should be administered. So, what we need? We should change our attitude. In such problematic cases, we should not do a blame game. It was his fault, it was her fault, it was their fault, it was not me. So attitude needs to be changed. And aim is to achieve healthy mother and healthy baby. So every mother's life and health is precious. So we should put our maximum effort and expertise to save the life of the mother, because all mothers, all pregnancies, they are precious.